Welcome to AETCM, the Emergency Medicine channel. So, shall we?
Yeah. So what we'll have a case scenario. We have got a 20-year-old boy who has come to your emergency room with some uneasiness to his chest since last 30 minutes. So that is the scenario for you.
Sir, and after arrival, patient initial 10 seconds, patient was conscious or
Conscious oriented, he is sitting and he is walking around in your ED. But for the purpose of examination, we have made him lie down.
Okay, sir. On going to primary survey, airway was
Airway patent, no secretions, is talking.
Breathing part.
Breathing part, SpO2 100% on room air. Respiratory rate is a little bit anxious, but 30 breaths per minute.
Going to circulation, sir, heart rate.
Circulation heart rate is 180 per minute with a BP of 120/80.
Okay, sir. Disability part, patient is full.
Conscious oriented, fully conscious oriented.
On the circulation part, we connected the patient to cardiac monitor. And,
Cardiac monitor connected. This is the rhythm that you are seeing in the cardiac monitor.
Okay, sir. Then patient is vitally stable. We are going with to 12-lead ECG.
Okay.
Then
So 12-lead ECG taken, and this is the 12-lead ECG for you.
So patient had any history of chest pain, any altered
No chest pain, no altered mental status. He is conscious oriented, fully conscious oriented.
So we go into ECG showing regular narrow complex tachycardia.
Regular narrow complex tachycardia.
Which is rate around 179.
Okay.
So with the vitally stable, we can go with head diagnosis of a supraventral tachycardia.
Okay.
Stable.
Okay, so we have a diagnosis of a supraventricular tachycardia, which is stable. Why you are saying it is stable? Patient is conscious oriented, no chest pain,
No altered mental status,
no altered mental status, no hypotension. So it's a stable supraventricular tachycardia. So what you will do now?
In stable supraventricular tachycardia, we can go with the carotid sinus massage and Valsalva and modified Valsalva maneuver. In carotid sinus massage, we will give massage over the carotid area that is between the angle of mandible
and the
above the superior border of the thyroid cartilage.
okay, somewhere here. Okay.
So, before going to carotid sinus massage, we will check for carotid bruit to prevent any embolism.
Go ahead. No carotid bruit.
So after that, we can give carotid sinus massage with this for 5 to 6 seconds.
Okay. 1, 2, 3, 4, 5 seconds.
Check for the monitor to rhythm is reverting to normal.
It's not normal. It's again in the higher range only. So we don't see any difference.
If it is not reverted, then go on with vagal maneuver. We can do Valsalva maneuver. In Valsalva maneuver, ask him to make the patient to semi-recumbent position.
Okay.
Give him a 10 ml of syringe without needle. Ask him to blow through the needle for 15 seconds. While blowing to 15 seconds, we check for the rhythm going to normal.
Okay. Again, it is not improving.
Then we can go with modified Valsalva.
Okay.
And semi-recumbent position. Ask him to blow around 15 seconds. After 15 seconds, make the patient supine position and lift the both lower limbs for 15
seconds. Okay.
Wait for 15 seconds. Then makes the leg into normal position after 15 seconds. Again, make him to semi-recumbent position.
Okay.
Then check for the rhythm becomes normal.
Okay. So that is the modified Valsalva. So we'll have another video on this so that people will get an idea about this. So modified Valsalva. What we are trying to do, what will be this thing? We are trying to stimulate the vagus stimulation so that the heart rate will come down. So when you are raising the leg, there will be venous return and there will be increased sympathetic vagal tone, as a result parasympathetic tone, and there will be bradycardia. So the heart rate should come down. So it has little bit come down, maybe 165, but still on the higher side. So what else we can do right now?
Then after these things, we can go with give adenosine.
So we want to put an IV access?
Yes, sir. IVS is we put on more proximal.
So yeah. Go ahead.
More proximal to heart, we put preferably left hand with the cubital area.
Okay.
We can put an IV cannula of 13 gauge IV cannula with a 3-way cannula in it because and make the adenosine at first dose is 6 mg and take a normosaline flush of 20 ml.
Okay. So pediatric dosing, can you just tell?
0.1 mg
per kg. And again, for a quick overview, Valsalva maneuver, pediatrics, what we will do?
We can make ice packs over the forehead over the
ice. Okay, so 6 mg of adenosine is the dose. So any concerns before giving adenosine?
Before giving adenosine is related contraindicated in bronchiasthma and COPD patient. And before giving adenosine, we will tell the patient it will cause light headedness and uneasiness, and also make ready with this crash card. With us.
Okay, and any drugs that you wanted to ask the patient is on?
The theophylline
and dipyramide. So these are the two drugs that might interact, and the same thing is happening in your ICU. So any modifications for that? With the patient on a center line?
Center line, you can give the half the dose of the 6 mg, 3 mg is
more than enough. So adenosine, it's a relative contraindication, but still you can give it in asthma and COPD also. But what does adenosine does?
Adenosine basically it will delay the AV conduction, so it will
AV nodal blocking agent basically. So adenosine you are given 6 mg of adenosine given. And what else you wanted to do?
Lift the that limb after giving the flush. Lift the upper limb. So within the action is 20 seconds. So within 1 to 2 minutes, you look for any reverting the rhythm to normal size.
Normal. So it has not reverted. It is still the same.
Then we can give double the dose. 12 mg. We can.
Okay. So 12 mg of adenosine. You can repeat. So 12 mg of adenosine given followed by a saline flush.
Lift the limb.
Okay. So the heart rate is coming down. So the heart rate is coming down. Let's wait for some seconds. Yes. So from it has come down to 130, 125. It has come down to 105, 97, 90. Okay. So the heart rate have settled down. So what will do when you don't have an improvement with 12 mg of adenosine?
Then we can move with rate controlling drugs like calcium channel blockers, beta blockers. In calcium channel blockers, we can give diltiazem or verapamil. Beta blockers, we can use metoprolol.
Or else we have amiodarone. We have amiodarone with us, so we can use amiodarone also. But when you have ACLS guidelines, they say 12 mg. But the UK guidelines, they can go one more 12 mg can be given. So that is the major difference. Then if it is not getting reverted, or imagine that this patient is having an unstable SVT. So what will be the management?
Unstable SVT management is synchronized cardioversion.
Synchronized cardioversion. Joules of energy that you want to
start at 50 joules or 100 joules. Low energy.
Lower energy is only required. So where you need higher energy is usually in atrial fibrillation. So after reverting back to normal, what will be the next step? You should take a 12-lead ECG. Why you want to take a 12-lead ECG?
Because SVT with any accessory pathway, any aberrancy, we can rule out. We can, with the tachycardia, we cannot identify that.
Okay.
So after reverting back, we will take an ECG to look for any accessory pathway, like in aberrancy, SVT with aberrancy like LBBB or RBBB, or SVT with accessory pathway like WPW syndrome.
SBB with RBB would have come to know with the ECG itself. We'll have a wide complex tachycardia, but other one we will not be able to find it out. Okay, so
and any we can rule out any MI which will causing the SVT.
Okay, fine. So can he go home?
Stable patients,
they can definitely go home. Once it is reverted, you can keep them observation for a couple of hours, and they are fine. You can send them home. And sometimes there might be recurrence of SVT. So that time only we need to put them on some calcium channel blockers, depending upon the. But routinely, nothing else is required. You can discharge them. But if the patient is anytime hemodynamically unstable, or you have other comorbidities, you have other electrolyte disturbance, they should be inside the hospital. So SVT is a simple thing, supraventricular. I'm not going to discuss how to differentiate AVRT and AVNRT, which we have already done in the case scenarios. Our aim here in this case scenario to identify a narrow complex, regular, stable tachycardia and its management. We name it as SVT, but narrow complex, irregular, which is atrial fibrillation, which we already had discussed. So you have anything else to be added on?
With SVT with aberrancy usually present with wide QRS complex, and with this VT we can differentiate by Brugada criteria.
Okay.
In this criteria we can check for VT like if SVT with aberrancy, we have LBBB or RBBB morphology in ECG. Then precaudal chest leads, that V1 to V6 chest leads have concordance is there. That is positive concordance or negative concordance. In positive concordance, there is R complex only there. In negative concordance, QS complex is there. Then if there is, check for RSR dash pattern, but in RSR R dash pattern, in RBBB, right rabbit ear will be there. In RSR dash button VT, it will left rabbit ear pattern is there.
Okay.
Then AV dissociation, check for AV dissociation, capture beats.
And fusion beats. So the capture beat, fusion beats, AV dissociation, and extreme axis is all suggestive of VT. See, VT they can present with stable VT. We can have unstable VT. We can have VT in cardiac arrest also. So VT is one rhythm. You can have three possibilities. Completely stable patient, just like SVT, they can come and sit in front of you. They can have instability like hypotension, chest pain, they will also be there. But in cardiac arrest, you will. But the difference is the management. So initially you have a stable VT, what is the management that you need to consider? You can go ahead with amiodarone. Unstable VT, it's cardioversion. Any unstable tachycardia, it's simple cardioversion, 100 to 120 joules you can select. Then cardiac arrest, it's defibrillation is the treatment of option, followed by refractory VT, VF, we have already discussed that. Okay. So that concludes our okay.
I think if you take after reverting back, if you take an ECG, if it is W pattern, better to not give adenosine like drugs because there is an acid pathway there. So if you give a AV conduction block, it will again precipitate. So initially we cannot. It is
very difficult to identify initially, but later on, yes, we might be able to say that. Okay. So what will be the treatment for WPW syndrome then?
That is, we can give antiarrhythmic drugs like procainamide.
The definitely treatment would be radio frequency
ablation of the acid.
What is the worst possibility complication of a RFA?
Complete heart block.
Complete heart block. Fine. Okay, fine. Thank you. Yes. You have anything else to be added? Nothing. What we missed, Sreya? Nothing. Okay, fine. Pretty nothing. Okay, fine. Thank you.
To AETCM, the emergency medicine channel. Today we are going to discuss about modified Valsalva maneuver. Modified Valsalva maneuver is a non-invasive vagal maneuver that serves as a first-line therapy for the termination of the stable paroxysmal supraventricular tachycardia. So prior to the procedure, we are supposed to connect the patient to a rhythm monitor. Then we will be asking the patient to be in a semi-recumbent position at a 45-degree angle. Then we will be asking the patient to blow air into a 10 cc syringe for at least of 15 seconds, and it should be sustained for complete 15 seconds. Next, immediately lay the patient in a supine position and elevate the limbs at an angle of 45 degrees. This will help him to improve the venous return and increase the vagal tone for 15 seconds. Then again make the patient into a semi-recumbent position to complete the Valsalva maneuver. In the Rivet trial, the modified Valsalva maneuver has a success rate of 43%. So if the modified Valsalva maneuver, if it fails, then we are supposed to go for the other types of vagal maneuver that includes of carotid sinus massage and the intravenous adenosine. So we can make practice to explain the procedure to the patients and the family members to get self-practice. Thank you.